el final de este simposio de complicaciones. El doctor ya lo presentaron el día de ayer con su conferencia magistral, pero bueno, pues es el doctor John Gebhart. Él es ginecólogo y uroginecólogo por la Mayo Clinic College of Medicine, maestro en ciencias, es prolífero en el área de investigación y educación. Tiene múltiples premios y reconocimientos y bueno, pues su currículum es bastante extenso, pero bueno, el día de ayer ya tuvimos el honor de escucharlo en su plática de cirugía vaginal y bueno, pues el día de hoy nos va a hablar sobre hemorragia. Bienvenido, doctor.
Gracias. Buenos días. This will be a very important lecture because most of us are not used to dealing with bleeding that it can be catastrophic bleeding. So the take-home message is that you must prepare in advance. You must have a plan in advance before bleeding starts so that you know what you want to do, because the bleeding will make you panic because you're not used to it, and it'll lead you to poor choices. So you want to think about it in advance and plan in advance. Much like in obstetrics for shoulder dystocia and emergencies like that, you have a plan that you're going to do if you encounter that. So think about this in your practice and how to manage bleeding. Here are my disclosures. This is one of my favorite pictures. Arnulfo Martinez was the distinguished Lee lecturer at Mayo, and we're in William Mayo's home, and he's sitting at William Mayo's desk where Will Mayo used to see patients. And so Arnulfo's a great friend, has introduced me to so many people in Mexico, and I'm so honored to have these friendships and to be here. And thank you, Arnulfo. We're going to look, yes. We're going to go through a couple of videos that are rather dramatic that show you maybe what not to do when you encounter bleeding. So attempting a cystectomy. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. Poor choices. This is a hole in the external iliac artery, and grabbing it initially traumatizes it more. A bipolar forceps, terrible, right? You have to preserve the arterial supply to the leg, so poor choices because you panic. You haven't thought about what you would do if you encountered that situation. Something for the urogynes. This is a hysteropexy that they're doing. Nice knot. Poor choice, right? Sloppy, Poor technique. You see the hematoma forming. They're going to open that patient and fix it. This is a patient who has undergone a sacrocopepexy and a rectopexy, and they're going to be corkscrewing the rectum to the sacrum. Poor choices. Always expose the area so you can see what you're doing and what lies beneath. This is a tacking device. Poor choice. Watch when they slip off the sacrum with the tacking device. Didn't get it? Watch them slip off. Poor technique. Don't let this be you. Now, blind clip application. They've got into the internal iliac vein here. Poor choice. You can't see anything. What are you burning? Must expose it to fix it. Blind cauterization, no good. You see the sucker there. Putting some pressure is helpful, but temporarily, only when they're in the right spot. Now, surgical clips. Again, can't see what you're trying to do. Clips. One. Two. Three. Four. Five. Where's the ureter? Where is the vessel that's bleeding? 6. 7. 8. Good move with the sucker, pressing on the left common to decrease the flow. Some direct pressure. Should I open this patient, right? Am I accomplishing control of the hemorrhage? Pressure right here. I would continue holding pressure and open the abdomen right now, right? You can do that and still make an incision and open the abdomen if you need to, depending on your skill set and so forth. 30 seconds to get a Ratex sponge in. Poor choice, right? Keep holding pressure. You don't need the Ratex. Think about managing bleeding. What will you do? You must have a plan. So, just some basic review. You must know the anatomy, especially the vascular anatomy, but the neuroanatomy that runs with the vascular anatomy, that's just an absolute must, okay? That's the starting point. Let's go to that slide. I don't have a good picture. These are from the netter, but you must know the sidewall anatomy, especially the vascular and the neuroanatomy, because that's where you're going to have catastrophic bleeding, as well as potentially at the vena cava and aorta at the sacral promontory with sacrocolpopexy. Some basic reviews. Remember that venous bleeding is coming back to the heart. Venous return. It's high volume, but low pressure. If you get into a large vein in the pelvis will suddenly fill with blood because of the high volume of blood that's returning. It's low pressure, but it will well up very quickly. In contrast, arterial bleeding is going away from the heart, so it's high pressure, but low volume. So arterial bleeding will shoot across the room if you're doing an open, or across the screen if you're doing it laparoscopically or robotically, so you can know to some degree what's bleeding based on what you're seeing in front of you. Very important. All veins in the pelvis may be ligated except the external iliac. That's the primary venous return from the leg. So if injured, it must be repaired. Same applies to the artery. These are from my good friend and colleague, Dr. Magrina, Javier Magrina in Arizona. This will be a robotic repair, but think about doing this laparoscopically if you have those skills, or through an open approach if need be. External iliac vein injury with repair. So they're putting a little pressure up above with the arm to diminish venous flow so that they can see. This is a small vascular suture that's got a lapra tie already on it, so he doesn't have to tie and take those important minutes. Want to see the defect in the vein and get above it, very important. So you're getting above the injury right away. Very important as well, the irrigation, so that you can see. And you see as well how the vein collapses when you enter it. And it's important that you don't sew the top of the vein to the bottom of the vein, therefore obstructing it. You must be very precise and particular with your suture placement. So again, the irrigation helps you see, very important. And very nice technique by Dr. Magrina Wachi. The suture comes down, doesn't like where it is, places it precise. Very good technique. See how he follows for himself to bring it up. Also helps stop blood flow from leaking out so that he can see. What would you do? What is your plan? And then gets to the beyond the defect, and then another lapra tie will come in so that he doesn't have to mess around with the suturing. Very good approach to bleeding. This is a hole in the vena cava that he's going to repair robotically. We're looking from the pelvis to the sacral promontory, so the patient's head is at the top of the screen and the pelvis is at the bottom of the screen, just to orient you. You see where the arm of the robot is, right on the aorta, the vena cava just to the right of it. He's holding the hole closed with the instrument so that he can get started, diminishing the blood flow so that he can see. You see the suction right below, as well as the irrigation. The labrati already fastened on. Pretty good hole in the vena cava there. What would you do, and what is your plan? Think about it, prepare in advance, because if you suddenly have a hole in the vena cava, it's going to shock you, and you're going to make poor choices. See how the irrigation helps you see. Very, very important. Now I'll share two of my cases. This is presacral bleeding. We're doing a sacrocolpopexy. I put the stitches in, and I have some bleeding. It's not terrible bleeding, but it's not bleeding that you're going to put a drain there and manage. You're going to have to manage it accordingly. I like to put my sutures about at the S2 level. If you get deeper than that, you'll definitely can get into venous bleeding that runs sort of across the sacrum at that level, and that's what we got into with one of our sutures. Just holding pressure is good. Someone said, oh, let's try the flow seal, right? A good choice, but after you've controlled the bleeding better. In this setting, no good, because we've got more bleeding than the flow seal will help address. Holding pressure for a minute or two, still bleeding, right? We have to visualize where our bleeding is and decide how we want to manage it. Two areas, so we're going to work down from the promontory to where the bleeding is, and then I like, especially in the midline of the sacrum, in the anterior longitudinal ligament region, to use cautery, turn it up to about 60, and on a spray mode, works very well in this if you're in the middle. You don't want to drift out laterally and be indiscriminately cauterizing things that you don't want to. So we had a little bleeder up above. Now we're dealing with the bleeder down below. You'll see a little arcing of the cautery as we do that, not a problem, but just stay on it and cauterize. You can get into the middle sacral vessels here. It's not a big thing. I usually don't cauterize that. You'll see now where we've dried it up very nicely, just lateral to the anterior longitudinal ligament there. And then we'll put a little flow seal in and then tie down the mesh and then reperitonealize, and we're in good shape. Here's a very challenging case. A patient that had had cervical cancer, radiated for that, developed vulvar cancer, radiated for that, so external beam radiation twice. She has a vesicovaginal fistula that involves the right ureter where it comes into the bladder, and they had advised her she needs removal of the bladder and a conduit, and she wanted to try to salvage the bladder if able, and so we told her that we would attempt to do that if we could. Extremely fibrotic along the side wall. It's hard to know, even with the stent in. You can see the bladder's open. We've got a stent up the ureter on the right side, but this is like wood along the side wall. This is the ureter that we're getting under here. We'll put a vessel loop around that just to help identify that, and we want to follow it down, but it is plastered over the external iliac vessels and along the side wall. So we need to bring this off our external iliac vessels. I'm nervous. Yep. Very fibrotic. It was tough to feel the pulse, to know that I'm over the artery or not. So very shortly here, I'm going to get into the external iliac vein. We get past the artery fine. If I had the choice, but the good Lord doesn't give us that choice, if I had the choice, I'd rather have arterial bleeding to manage than venous, because you can see it well. Venous is going to just fill up very, very quickly. So we're just trying to free the ureter up. We're getting past the artery. And I'll get into the vein here very shortly. We have a camera in the overhead light that we can record or take pictures through, and that's how we're filming this right now. Wasn't planning on filming bleeding, but that's what we did. So I get into the vein here. So control with the Russian. Actually, the fibrosis was actually pretty good control. If you let go of that, it tamponaded it nicely. I'm trying to get at the hole, but I don't have enough room to suture it. You have to mobilize the ureter and the vein to get at the defect better. So trying to expose it more is going to just show us more of the bleeding, but you've got to be able to see it. So best hemostatic agent you have is your index finger. Okay? Hold pressure. Anesthesia, we've got bleeding. Make sure we've got good IV access. Get blood products ready from the blood bank. Call for help. I need a colleague who's operating in the vicinity one of my GYN oncology colleagues, a vascular surgeon if we need to. Okay? Ask for help. You'll take any help when the chips are down. If that's another gynecologic colleague that you can help expose and help you through this injury, that's a good move. So now we're just mobilizing further so that we can see the defect in the vein. We can put some vascular clips on to just diminish the flow, but you've got to see it to fix it. Here's a nice move, a narrow Alice, clamping on the defect in the vein to control it now. Okay, good. We've got control of the bleeding. Let's mobilize further so that we can see the defect and then be able to suture it to repair it. Very fibrotic. Maybe in retrospect, should I have operated on this patient or not? I think about that. We were eventually able to reimplant the ureter to fix the fistula, but very difficult situation with bleeding along the sidewall, especially if someone's been radiated before. The peritoneum and everything will almost vacuum shrink wrap against the sidewall and everything is stuck down. So now we can get at the defect to suture it. You control the bleeding. There's a little vascular clamp on the distal vein because remember, blood's coming back to you. That's where the flow is coming from in a venous injury. In arterial, you would want to occlude it proximal to the injury because the bleeding is going to the injury and beyond. So the injury is repaired, things look good, but a little hard on the coronary vessels when something like this happens. So you want to think about it, you want to have a plan of attack. There's the vascular clamp coming off, looks good. Now we can try to further mobilize the ureter to ultimately reimplant it. So, control the bleeding, an atraumatic instrument if you're doing it laparoscopically, if you're going to grab anything. Direct pressure, very good. Communicate with your anesthesia. Ask yourself, do I need to open this patient or not? Or can I control this laparoscopically or robotically? Direct pressure is always a very good move. If it's venous, a little proximal to the injury. If it's arterial, different. Can I ligate this? Do I need hemostatic agents? Do I need a colleague to come help? Here's a picture of a vascular cart that we have in our core so that if you had a major vascular injury and needed a vascular surgeon, everything they need is set in the cart and can be wheeled right into your room. Planning in advance for these types of rare but catastrophic conditions. Have a plan. Muchas gracias.